program for women with provoked vestibulodynia or vulvodynia or both?
So vulvodynia is an umbrella term, it's not a diagnosis. Vulvodynia just means pain somewhere in the vulva. So this program is specifically for women with the subtype of vulvodynia called provoked vestibulodynia or PVD, which is a specific diagnosis. And it's the most common cause of painful intercourse in women.
Thank you. So what are the aspects that make the MVP program unique?
I think the multidisciplinary aspect of it, where there are different providers in-house together, seeing the same patients, discussing treatment outcomes, making recommendations to the family doctor together, is what makes the program really unique. It's, to my knowledge, the only one of its kind in North America, where you have gynecology, mental health, and pelvic floor physiotherapy specialists, again, together under one roof.
And how did this program get started?
So in 2008, Mrs. Leslie Diamond wanted to donate some funds for the good of women's health to establish some kind of clinical program for women's health. And there was a call for applications, and myself and one of the gynecologists in the previous vulvar pain program, so Dr. Leslie Sudonic and I, came together, and we had been having some discussions about how different multidisciplinary staff come together to work with women with genital pain. And so we thought it would be a good opportunity to send in an application, and we did, and had a chance to meet with Mrs. Diamond, present the idea to her, and she funded it.
That's great. And the main reasons you think for the program, like who's the major driving force? Basically, was there a call out from patients, or was that more the doctor's initiative, or?
I think because the vulvar pain clinic had a 2 to 3 year wait list, and so of the enormous unmet need among women, that it was just leaving many of the gynecologists in the program quite frustrated that they couldn't provide adequate care, they couldn't provide follow-up care, there was disjointed care because women were maybe getting pelvic floor physio or seeing a psychologist in the community at different stages. And so that's where the need came from, was kind of the current state of affairs within the previous pelvic pain or genital pain program.
What are some of what's the program's mission statement, or just goals and objectives?
So the goal is to provide in a short-term, condensed, but highly intensive format an overview of the major effective treatments for PVD. We're under no illusion that women will come out of the 10 to 12 week program and have their genital pain cured, but they will know a lot more about the condition than when they started. They will have been exposed to many of the different kinds of treatments, and then ideally working together with their primary care provider, they will be able to do the ongoing long-term management plan so that they can eventually experience some pain relief and ideally overcome this condition.
Mm-hmm. What were some of the barriers or challenges that needed to be overcome to get the program up and running?
The most obvious one is the lack of awareness around PVD. So even at the time of presenting this idea, this proposal to Mrs. Diamond and to various members of the Vancouver Foundation, Hospital Foundation staff, they had never heard about this condition before. And there were maybe some assumptions or misinterpretations that, well, isn't this just like what all women go through when they go through menopause? A bit of dryness, a bit of pain, you add a bit of estrogen and things are fine. And so it took a little bit of sharing patient stories, really deeply compelling patient stories, to have Mrs. Diamond and some of the hospital staff really understand that, wow, this is a very common, distressing condition, and it's worth us investing some money in.
And so what are some of the changes that you've seen from then till now, maybe in the medical community, because of the program?
I don't know that there's been any change because of the program. I would like to think that with our website, and since part of the website is devoted to healthcare professionals, I would like to think that it's increased awareness and education among care providers, but I don't know that it has. I don't know that it has translated into improved care. But I think what I'm seeing more globally is increased recognition that this is a real problem, that it is a distressing problem, that we need better treatments, that we need more science to understand what causes it. And so overall, in the last 5 years, there's been an enormous surge in interest and research in trying to understand this condition.
Great. And who are some of the biggest supporters you're finding right now for the MVP program?
Certainly the women themselves that benefit. They provide unsolicited testimonials about how positive an experience it was for them. Many of them offer to speak to fundraisers or potential donors, or to go to the media to share their own story. So they're quite grateful. And I think at a departmental level, we've been able to provide a really important service. And we've cut down waitlist times as a result of the program. So there's some recognition and appreciation at the department and university level for that.
Okay. What are some of the resources and sources of support facilitating the program right now?
Until now, there has been a little bit of hospital support in helping to pay for the program coordinator's salary, and unfortunately that's ended now. And so all of the funds to operate the program are coming from this small donation from Mrs. Diamond. So there are concerns about long-term sustainability, because once the funds dry up, we don't have an existing pool to continue to fund it. So we need donors, we need fundraisers, we need people who are willing to invest in the program to keep it going.
And so how many women have been through the program already?
Approximately 230 to 250, approximately.
And
Now that's probably including some women that, for different reasons, have not been able to finish the whole program. So that's probably all women that have been assessed and been enrolled in the program.
Okay. And what do you find, maybe just off the top of your head, are some of the main demographics or something that stands out for you with the women who are in the program right now? Or
So we did an interim analysis on the first 150 women, and so we do know a little bit about the characteristics of women, and they tend to be educated. They tend to be largely Euro-Canadian, with a smaller representation of East Asian, a few Indo-Canadian women. They tend to be just as likely to be in a relationship as not in a relationship. They tend to have an income as well. So although we have a few students, the majority of the participants do have some form of income. And in terms of sexual diversity, most of the women, following just the diversity in the population, most women are heterosexual, with about 2% of the women being non-heterosexual.
So you found that half of the women that have been in the program, or maybe not half, are equally as in a relationship, or is it not in a relationship?
Yeah, it's about half are partnered, half are not.
And Lori, what contact do you have with participants, if any, or what is your role right now in the MVP program?
So my role right now is program director, so I oversee general management of the clinic, lead meetings, lead new initiatives, look for funding. Previously, I was the psychologist on staff, so I would lead the cognitive behavioral mindfulness-based groups. I designed the content of those groups, and now we have 2 other therapists who are leading those sessions.
Now that you mentioned the CBT, my next question was what is the role of CBT and mindfulness in the MVP program, and how can it help women with PVD?
So it's an integral part of the program. All women take part in 3 group sessions that are a combination of cognitive behavioral skills and some mindfulness skills. Because there are only 3 sessions, there's not a lot of time for in-session practice, so women are given a binder of exercises to take home and practice on a daily basis. This stems from a bigger literature which is really supporting the role of cognitive behavioral, and more recently mindfulness, in particular skills in chronic pain and in PVD in particular. So we know it has a very important role to play. When we carried out a qualitative study in the early stages of this program, when we interviewed about 20 women on what their experiences were like being in the MVP, they unanimously said that it was the groups, the CBT mindfulness groups, that led to the most improvement for them. So we have some self-report data suggesting that it's helpful, and we have not yet looked at the harder outcomes, the quantitative endpoints, to see changes in things like mood and distress and reduction in pain itself.
And what would you say is the role of the pelvic floor physiotherapy?
So again, pelvic floor physiotherapy is another very important component of care. With pain, there could be this secondary tightness in the pelvic floor muscles. In other women, the opposite direction happens. Pelvic floor muscles are tight, and it might lead to a predisposition to genital pain. Regardless of the pattern of direction, we know that many women benefit from pelvic floor physiotherapy, in particular biofeedback with EMG sensors. And so women in the MVP also take part in 3 individual one-on-one sessions with our pelvic floor physiotherapist.
And then I understand there's an educational component as well.
Yeah, because there's still a lot unknown about what PVD is, and often we hear stories from women who will say, it took me several years to even get a diagnosis. For the first 3 years, different providers I saw assumed that this was a yeast infection, or assumed that I wasn't relaxed enough, or assumed I had sexual hang-ups, or told me to go home and have a glass of wine. So there's a lot of misinformation around what it is, how prevalent it is, what are the unknown underlying causes. So the first educational seminar, which is led by our gynecologist, is just about establishing what do we know about this condition, establishing its name, its prevalence, some of the known causes, and all women receive that right at the outset before they then undergo different aspects of treatment, to ensure that they have a kind of a common working knowledge on what PVD is.
Great. And what's going on now with the MVP program? Like maybe what developments have happened recently, or what you're excited about?
Well, I'm excited about the research aspects that in the last several months as a result of the first wave of analyses, we have some new questions that we want to answer, like what's the impact of women's expectancies and what's the impact of their beliefs about what works on their change. So we're really excited about that. We're also excited to start looking at the partners as well. So we have a partner study under development right now, where we'll be interviewing a handful of partners to find out their perspectives, not only of having a partner with genital pain, but what's been the impact of the MVP on them, and is there something that the program can offer these partners. Of course, there's lots of other smaller research questions that we'd be interested in. We've got a good sample of women in order to test some of those hypotheses.
Great. So what do you see can be done in the future? What changes are being planned or need to be implemented, do you think, to keep the program going or make it better?
I am concerned about long-term sustainability. We need to secure funding immediately, or the program just won't be viable. It just won't be sustainable in the future. So that's kind of an immediate concern, and with no immediate answers to that so far. So again, we're looking for potential donors. We're looking for potential investors who might be willing to invest some money in the program. We're very interested in exploring with the hospital to see if they might be interested in funding this program, or at the ministry level. So those are some of the more immediate things, and with some security in place, that will allow us to not only continue the program, but be able to develop bigger and better research trials to examine some of the things that we don't know, like looking at different experimental treatments, or maybe looking at neuroimaging, what actually happens to the brain in these women as they undergo multidisciplinary care.
And what current evaluations are being done on the program? I know you mentioned some of them before, like you've done qualitative research in the past. Is there anything else particular you'd like to?
So every woman completes a battery of questionnaires at 5 time points over the course of her involvement in the MVP and up to, several months and a year later in the program. So those are some of the quantitative self-report endpoints. We're also interested in pain itself, and so with the gynecologist and the physiotherapists who actually do a physical exam, they're able to get pain ratings from women, and we might be able to see if actual pain ratings during penetration might improve over time. Ultimately, the best measure is the woman's own self-report, though, when she goes home into her life and says, I feel a bit better, my mood is better, I'm not worrying about pain so much, or intercourse hurts a little bit less, or I'm starting to have desire again, or I want to be close to my partner, or I'm not afraid to be in a relationship anymore, I'm saying yes to dates. Those, I think, are the bigger quality of life measures that would ultimately speak to the importance of the program.
And then what happens after a woman's completed the MVP program?
So in the past, we've done a booster session where we invite women back, and we have a 1-session kind of booster in skills. We're just reevaluating that, and we're going to be doing those booster sessions pre-recorded and putting them online so that women who geographically can't make it to the clinic might still be able to benefit from those sessions. And then there's the questionnaires that she's asked to fill out for up to a year afterwards as well, after she's done the program.
That's great. So that's basically all the questions I have, since you've answered all the rest. And do you have anything that you'd like to add, or something specific that I might have missed?